I was looking, yeah.
It's on your thing so you can see that they do, because it's very exact. If you're talking about working in a burn unit, you are calculating it based on this person, just like WT. That you had an arm, you had a leg, or you had a torso, or you had whatever it is. That's all you're going to have. I'm not going to say that he burned everything except one finger. Because if you are on Von Browder, you have to figure that out. Because they actually give a value to every single piece of your body. But that's something that's done for a more precise thing. Rule of nines is just so you can do a general survey to say how much body surface area is burned and then apply it to a patient situation. So it'll either be a whole arm, a whole leg. It'll be if you say entire torso, that's front and back. If you say anterior, that's just the front. If you say posterior, that's just the back.
Yeah, I guess that's my question. If it's a torso and it's just in the front, like it's still considered 18.
That's 18.
Right.
But if it says whole torso, it'd be 36.
Right, because it's front and back.
Okay, that's basically what I was
Miss Henderson, my uncle got burned. He raced his cars and the water pump came loose and he had to drive until he got signal. And he had all his back was the skin. It was white to, is that like partial?
It depends on how the depth of what. If it was very painful, he had blisters. More than likely, it's 2.
Yeah, I think he had blisters, but you could still see his, like the tattoo he had on his back. But his skin was gone, and then he had to end up getting pig skin.
Yeah, because they do. I mean, pigs are, sad to say, pigs are closest to human in a lot of things. As far as using their skin grafting, we also use their valves. And when a patient has valve replacement, you can use a pig valve. So, not if you're Arab. Not if you're Muslim, I should say. Because we have patients that, we had a patient at one time that they did it, and he said, I can't do this.
Well, we're not allowed to eat it, but I don't know in terms of people.
Our patients,
That is like saved my life.
Saudi, everybody doesn't see it that way. Though. Some people are so, I mean, they're just like, and I don't know that the doctor even thought about it. And I was just like, dude, did you ask the patient beforehand? Because it's also like that sometimes when you're talking about women giving, when they have delivery, they don't even want a man in the delivery room, period, in any shape, form, or fashion. And that's not, you know, there's some women that's like that. I don't like a male gynecologist either. So it's just like really, oh my God, kind of thing. So it's everybody's, you know, those kind of things you have to observe. But we actually had a patient one time that was done, and I don't think they even thought about it and just did it. Because the cardiologists I used to work with were retarded. That's the way I looked at it, because they really thought they could just do whatever. And then you'll see that a lot with cardiac surgeons, I'm just saying. But that's what happened after the patient found out after he had surgery. So he was kind of like stuck like Chuck, unless he wanted to go back to surgery again, kind of thing, which he didn't want to do so. But it was a lawsuit against the physician.
What?
Yeah.
Yeah.
Yeah, because that kind of stuff is that just a disregard for what people, you know, religious observance. So I understood why he said it, but the doctors were like, really? And I'm like, yeah, this is what happens when you're retarded. All right, because that's who I was. I can't help myself. All right, so that's the burn section. The other part is about renal, and the big piece of that is acute renal failure. Because all the other stuff that's in renal is like, you get it, all right? Because you had renal artery stenosis there. Renal artery stenosis was a patient who had, think about, you have that whole process of atherosclerosis that happening in the chest, can also happen in the renal arteries. So renal artery stenosis or nephrosclerosis is basically plaque formation in the renal artery. And when you have the plaque formation, decreases blood flow. Therefore, you have decreased perfusion to the kidneys. And one of the things that happens with that is activation of renin-angiotensin-aldosterone system, or RAS. Okay. So sometimes when you have a person who is on blood pressure drug number 5, and you're going like, we maxed them out on 5 medication, the patient's still hypertensive, doctor says, eureka. Maybe I need to check and see if they have renal artery stenosis. And when they go send a patient for diagnostic testing, you can do it by sonogram. You can go to interventional radiology, because if they think that's what's happening with the patient, interventional radiology is the place to go, because now I can also do treatment. So you go in and you do a plasty and a stent placement just like you do in the chest. For coronaries, you can do the same thing for your renal arteries. And when you do that, you blow up the balloon, open up the artery, put the stent there, increases blood flow, lowers blood pressure for about 70% of those patients. So that means that this person, 70% of the people are going to come off medication after you have this done. About 30% still stay the same. We don't really know why, but those people are still there. But a lot of it is that when you think about renin-angiotensin-aldosterone system, okay, that's why we use ACE inhibitors in there, right? That's because that's what happens with those patients. When you have renin release, also causes aldosterone release, which helps you retain sodium and water, because where sodium goes, water goes, increases vascular volume, raises blood pressure. Then you have conversion of angiotensin 1, which is a potent vasoconstrictor, into angiotensin 2, which is even more potent. So when you have that activation going on, it's just like chasing your tail. That's why the person's blood pressure never responds to medications. So that's sometimes what you'll do when you see a patient max out on drugs, because you've probably seen them, you give them to them when you're working with them. How come this person is on 4 drugs and is still not controlling their blood pressure? Sometimes that's what is the problem, is that you have a blockage there. The other thing in renal has to do with renal cancers. Still, I don't understand why that's in this class, because it's a slow-going tumor usually that patients have. Usually have some type of exposure to either, they've worked in chemicals. A lot of times you'll see different dyes that patients use. So a lot of people who work in industries that have to do with clothing, you actually see a higher incidence of patients who have kidney and bladder cancer. Okay? It does happen to other people, but that's what you see it in the most. And then, of course, smoking, because smoking is linked to all types of cancers. So the usual symptom that you see in these patients is painless intermittent hematuria. That's what the thing is. So they're not associated with anything, but all of a sudden they have blood in their urine. Most people sit there and go like, man, was I lifting something? Was I doing something? Especially during Irma, right? You're getting your house ready and doing stuff. You just put it off till I just worked a little too strenuously, and that's why I have some hematuria. Folks, hematuria is never normal. Right? For people, that's the kind of thing that people do. They go like, well, I was doing stuff. I'm like, dude, that is never normal. Okay? But it's the difference in it is that it's painless. So that's kind of what puts it, because painful stuff usually is associated with inflammation, infection. So you usually having other symptoms that go along with that. But stuff that is painless, you kind of put off because it's intermittent, it's not happening all the time. So that's why you put it off, because it's something innocuous, not causing a problem. That's what usually happens. But that's the thing you see in them. Okay. Now, if you have a person who actually has a kidney cancer, or that's actually happening in the kidney itself, sometimes you may have a palpable mass over the kidney itself. Okay, so that's one of those kind of things you see. Urine cytology, biopsy, confirmative testings that we see with the patient. And you may have patients, because for you guys, I already taught ostomies and that kind of stuff when we were in P2. My students in my other class don't have any of that. It's madness to me. All right? So just think about, you have a person that has the ostomy. Ostomies should be pink, moist. They should be draining, because in this case, you're talking about ileostomy, nephrostomy tubes. Maybe put in, if you have a patient that doesn't drain their kidney, we put those in. You just look for signs and symptoms of infection. Is the urine clear or cloudy? I would not go into great detail, because you can figure that out just by thinking about what's happening with your patient. Palpable mass for kidney cancer, painless intermittent hematuria, so you pretty much know that question is somewhere in the test, because that's what you usually see. Diagnostic by cytology, because if you do a urine cytology, it sheds cancer cells, but also biopsy that you're going to do with your patient. And anything you do to the kidneys, always look at H&H first and your PT-PTT. Patient has a bleeding problem. Remember, kidneys are very vascular. I punch this kidney, I'm going to keep bleeding, where your patient may actually have to have the kidney removed. So those are kind of things you look at as far as before they have their any type of procedures done. Okay. Trying to think of what else is in that kidney section that's on your sheet.
So cytology is like the, to confirm versus biopsy?
Cytology and biopsy. You can see cells on cytology, but they still will always do a biopsy.
Is there an outline for urinary? I found one for burns, but
Cancer,
It's in there.
kidney,
Whatever's on
bladder,
your,
prostate.
not. Oh,
Renal traumas,
oh, thank you.
renal vascular traumas.
I told you about renal vascular stuff. That was the thing about the vascular stuff. So trauma. At any given time, about 20 to 25% of your vascular volume is in your kidneys. Okay. That's why they are so sensitive to problems with low blood pressure. Okay. You think about how can they hold all of that? Microcirculation. So if you actually squeeze your kidneys out, took them out and squeeze them out, about 20 to 25% of your total blood volume is located in them. Okay? So anytime you have a person who has a trauma, it's always going to go back to kind of the renal failure thing, or what we're going to talk about with that. Always look at urinary output for the patient, because as perfusion to the kidneys get less, they're going to put out less urine. That's why one of the things they always talk about in test questions or stuff that you see practicing for your adaptive quizzing, one of the reasons they always ask you about looking at urinary output is because it's one of the indicators that's telling you something's going wrong with the kidneys. So if I see urine output go down, I'm worried. You always kind of think about it in that regard, because you should be processing urine all the time. And when you're not, bad things are happening. So when blood pressure hovers really low, that's what you're worried about. I'm not perfusing the kidneys. Think about them just like a heart attack. That's how you have to think about kidney function. And if you think about it that way, you're always sensitive to thinking about what's going on with your patients, so you don't end up with acute renal failure. That happens with your patients. Because that's the big thing. That's the issue more than all of this. I mean, as you talk about all those questions combined, that'll be, part of it. But acute renal failure is going to be what you need to know, because it is something, unfortunately, we cause a lot of time for patients. And it's something that can end up being, something you start off with, patient not having a problem, but later on can be very costly to a patient. That's the bad part when you think about what's happening with them. Okay. All right, so renal trauma, just think about, make sure you check blood pressure. Patients can have got a lot of vascular volume here that's happening with your patient. Look at your PT reports, look at CBCs. Because those are things you're thinking about when you think about the trauma patient. So look at urinary output. Now the big bear in this group is acute renal failure. So chronic renal failure you talked about in NP2 as a consequence of this, but also we talked about as a consequence of diabetes, increased perfusion, all that kind of stuff over time. But acute renal failure we talk about because it's a big issue that sometimes happens with patients. And you may see it when you're looking at your charts on your patients and they tell you the patient had an ARF or they had acute renal injury, acute kidney injury, or AKI, as they're sometimes writing. So you'll see those things in the patient. You're focusing on the acute side, not the chronic patient. Okay? So that's what you think about what's happening with your patient. So when we think about acute kidney injury, there's usually some type of assault or injury that happens involving the kidneys that can be very proximate, meaning close to the time that you see presentation of symptoms, or it can be out as far as 2 weeks previously that the patient had this problem. So if I had an episode of hypotension 2 weeks ago, I may end up in acute renal failure now. That's why it's important to kind of understand the mechanisms or things that are happening with your patients so that we prevent patients from having further kidney or permanent kidney damage associated with it. So your big thing is kind of think about who is your person at risk. Always think about your elderly person is going to be at risk, mainly because as the person gets older, you lose kidney function just in general. Even if you don't have disease, your kidneys actually start losing function at about age 30. So everybody in here has an issue.
30?
Oh, is that what it is? I was wondering.
All right? So just think about it. Those are things that can happen. Now, I'm not saying that it all goes away at the beginning, because that, you go like, man, what's the point? All right? Maybe just drink till I fall out. None of that. All right, but just know that you start seeing decreases in function over time. So just know that it's something that happens. And then when you think about adding chronic diseases on top of that, that's why you worry about patients who have heart disease, because they're not perfusing over time. Patients who have chronic anemia. All those things are things you start looking at what's happening with my patient. But the thing about it is I've had some type of assault that has happened by a variety of mechanisms, and we're going to talk about those things, that happen either proximate to when I start seeing these changes in a patient, or it can be as long as weeks away. Okay? So that's acute kidney injury you're thinking about with your patient. And they talk about rifle in your book, so you'll see both of those kind of connotations that are kind of used with that. So what happens is I've got to think about why is it caused. So there's three basic areas where you look at cause. That's the pre-renal, intrarenal, and post-renal. These are the major causes or the classifications of types of failure that your patient may have. Because something is happening, and it tells you that this person's injury, whatever it was that caused it or what happened to the patient, happened through one of these mechanisms. So pre-renal is anything that's outside of the kidneys. So that's anything before something gets there. So the major cause that you see here is hemorrhage, hypotension. Those are the kind of things that are associated with that type of injury in a patient. So that's why, you know, way back when you saw me the first time, I told you, take a blood pressure for a reason. Whether or not you give medication based on a person's blood pressure, I don't care how much I love the tick, I will take a blood pressure myself. Because you live with this once you give it to the patient. That's the reason why, because that hypotension may be there for a while. Okay, especially depending on what you gave the patient. Okay, so anything that happens outside the kidneys that's pre-renal, think about before it got there. That's how you think about before. So hemorrhage, hypotension, those types of things are things you look at for that. Those are prime examples because those are the most common reasons it happens in a patient. Okay. Intrarenal tells you that something happened in the kidneys. So something that I gave to the patient or something that's going on with the patient has caused damage inside the kidneys themselves. These are things like acute tubular necrosis that can happen to patients who have glomerulonephritis. So that's an untreated strep infection. So it can be from infection. It can be from contrast dye that we give because this patient needs to go down for an IVP, a CT scan, whatever it is that needs contrast. So that dye actually causes damage within the kidneys. Different mechanism, end result is the same. Can also happen in a patient who has an antigen-antibody reaction to blood that we just finished talking about. Basement membrane of the kidneys will start breaking down because the ABO complex is not compatible. Different reason, but the end result is the same. Okay, so intrarenal is something that happens in the kidney itself. Can be medication related because there's some drugs that you worry about because they have an affinity for causing problems in your kidneys. A lot of us probably take those, all right? Because Asadia said gentamicin, so think about those aminoglycoside drugs. But a lot of us in here take things for aches and pains that are notorious. Big drug is Motrin. Motrin is a wonderful drug when used like it's supposed to. But what generally happens when we go to the drugstore? You get it, you take it like Aunt Susie takes it, who goes to see her doctor, and he says take 800. On a vial of Motrin, it says only take 200 milligrams. So that's one tablet. How many people in here take more than one?
I think more.
All right. So I'm just saying, that's what ends up happening. And this, in the summertime, is the worst time of year because people get dehydrated, and you're taking these drugs. They have an effect on the kidney. Therefore, it ends up being problematic. So that's your people at risk. So those are the kind of things you're thinking about. Anything that's intrarenal, happening inside the kidney. Okay? I'm not telling y'all to not take your Motrin like you want. I'm just telling you. I'm like, what? I'm going to die if I don't take it. All right? So post-renal tells you something that's going to be interfering with outflow of urine from the bladder. Because if it can't outflow, what it ends up doing is causing backup. It can cause increased pressure inside the kidney itself. Patient gets hydronephrosis, meaning that you have all the urine backing up into the kidney, increases pressure in there, kills off nephrons. So outflow obstructions are things that doesn't let urine flow out. So guys have prostate, but if any person can have a stone. So if a stone gets caught in the ureter, urine can't get out, that's an outflow obstruction. Tumors that may be associated with cancer. So those are things that tell you I have some type of outflow obstruction I can't get past. So therefore the patient ends up having a problem. So that means I can have a person go into renal failure because he has BPH, severe. I can have that in a woman who has a huge stone that's just stuck. I can't get out urine. Because remember, urine's going to stay in the bladder, keep backing up until it goes up the ureters themselves and actually just cause that urine to be caught in the kidney, and therefore the pressure in the kidney gets greater, kills off the kidney. All of those reasons are reasons why your patient can have failure. Now your book has a whole lot even more listed, but just think about your people at risk. Anybody comes into you who's taken an aminoglycoside drug, person at risk. Anybody who came to you had a hemorrhage at some point, you got a trauma patient, blood pressure was low in the ER, they got the patient back, yes, the patient is doing better, I still have to worry about them developing acute renal failure because those are your people at risk. If I send a patient down to a contrast dye test, that's a person at risk. Even if they're not diabetic, because we know they're even worse, right? You take the metformin. So you already know they are, but you can have a healthy person, all of a sudden I need to go for this. We don't know why it happens in people. Okay. So those are things, in your head, think about that person at risk. And that's the piece that we sometimes forget. You should keep treating this person, you're not looking at your lab work every day, all of a sudden the patient is in, like my sister-in-law, with a creatinine of 12. Wasn't having problems before, kind of putting off her tiredness to other things, but that's what ended up happening. So this is the thing that you're going to see in your patient. Now then, what we also see are some phases the person goes through. So these are my causes, or my etiologies of why they happen in my patient. Then we have some phases that the patient goes through. Now some textbooks call it onset or initiation, but that's when you're thinking about this is when it happened to my patient. So this is what that incident was, why the patient has a problem. So that was that episode of hypotension. That was the administration of that aminoglycoside antibiotic. It was the time the patient had an obstruction of the prostate. So you're talking about when it starts to happen in my patient. Okay. Then we have the oliguric phase. This is when you're going to see urine output go markedly down. And the oliguric phase is significant for the amount of urine that a patient puts out per day. Always, always. Because you're looking at a person who puts out less than 450 mLs per day. So that person goes from their normal urinary output to now they're putting out less than 450 a day. That's considered diagnostic, so you got to think about what's happening with the patient. So during this time, you may start seeing some azotemia. So that means that you're going to start seeing some changes in that BUN creatinine ratio that you see in your patient. You're also going to see some changes in the specific gravity. But that's going to be a greater change when you get to the diuretic phase. But you're going to start seeing some changes in that. So lab values, looking at your renal panel on your patient, those things you may start to see changes in the patient. You may also see some physical things going on. Because if your body can't get rid of stuff, like it normally did, you're gonna have problems. Usually when you see patients who have acute kidney injury or acute renal failure are in a metabolic acidosis. Those patients also have high potassium levels. The body can't excrete kidneys when it's acutely injured. So that's what you see in your patient. So hyperkalemia comes back for this one. We saw that in burn injury patient, right? Same thing happens here. And you know what happens when they have diuretic phase, right? What happens then? You start to have more urine output, but something changes in how you were able to do it before. And this is something you kind of think about for yourself, because we do it especially the first part of the year. When we're eating right, doing well, we drink a lot of water, right? You notice how clear your urine gets? So, but your body is able to keep what you need and get rid of what you don't. That part is lost during this phase. So a patient doesn't selectively filter stuff that they need. That's why it's called the diuretic phase, because you get rid of everything. So you actually have to watch this patient for hypovolemia at this point. But your body also has a lot of electrolyte imbalances because you're getting rid of everything. You don't keep the potassium you need. You don't keep the sodium you need. You don't keep the chloride or whatever it is, electrolyte you're talking about. Your body no longer keeps what you need. Because that's the difference. If kidneys are functioning normally, they get rid of what you don't need and keep what you do. Now it's almost a natural thing for you sometimes when you're off a little and you go like, boy, I need to eat some salt. Your body tells you you need to eat it. Or you might want to trip. That's why we crave a lot of stuff. It's because your body needs it. It's not just because we want to eat bad stuff sometimes. A lot of times it is stuff we want to eat bad, I shouldn't say. But when you're talking about salt and those types of things, sometimes you do that because your body says you need it. But now your kidneys can't do that anymore. They kind of just do whatever, get rid of everything. You don't need anything. So I got to worry about shock in the diuretic phase. I got to worry about hypo when you're talking about your electrolytes in this particular patient. But the body's specific gravity pretty much stays stagnant, which is something that doesn't happen in a normal kidney. Because remember, specific gravity tells you how much things are dissolved in water and solutes and those types of things. Your body no longer is able to do that. So that's why your urine color changes when you drink a lot of fluid, because you're getting rid of stuff you don't need. But you'll see that you actually can change osmolarity because you just keep what you need. Your kidneys can't do that anymore. Okay, so you usually see a fixed specific gravity during this time. So instead of going up and down, you don't see that. Glomerular filtration, those are things that, because that's something that's happening all the time. As blood goes through the kidneys, you're filtering things off. So that efficiency of that is also not there. Okay. Then we have the recovery phase. This is the part that we miss a lot of patients, because even if you have a patient who starts to get better, because during the recovery phase you see that, it's almost like you get stunned, like test day. All right, then the next day you come back and fight for another day, right? You're like, I can do it again. She keeps killing me, but I'm coming back. All right?
That's how we feel.